I'm Dr. Allan Perel, and this is Conversations in Medicine. This program brings cutting-edge medical topics to the New York City community. Today's program is devoted to thyroid disease. Thyroid disease affects about 2% of our population. We have different symptoms, people whose thyroid are underactive, overactive. We talk about nodules or cancer of thyroid disease, how it's an immunological disorder. We're going to talk about how important the thyroid gland is to us. And tonight, I have two marvelous guests, Dr. Philip Otterbeck, the Chief of Endocrinology at Richmond University Medical Center, and Dr. Lena Lekina, attending endocrinologist at Richmond University Medical Center. I want to say thank you for coming here, and I'm privileged to have such two wonderful guests.
Thank you. Thank you for having me.
Thank you.
What I'd like to start is what's the thyroid gland and why do we need it?
So thyroid gland is a gland that is responsible for making thyroid hormones. And if I may show that it is located at the base of the neck. And it is making certain hormones that are responsible for regulating metabolism. So if you want to think about a speed of each process in the body, thyroid hormone regulates that. There are millions and millions of cells in the body, and so thyroid hormones reach out to all of those cells in all the organs and regulate the speed of the processes.
So what's a gland? As an endocrinologist, you're a gland doctor, and people like to use that word glands. Why don't you tell us, what's a gland and what does it do and what the different glands are, and maybe give us some examples?
Yeah, so a gland is a part of the body that makes a hormone, right? So a hormone is a messenger, essentially, that travels to different parts of the body to tell that organ or that organ system to do something. So for instance, we have a pituitary gland, which is in our brain. That pituitary gland tells our thyroid gland to secrete thyroid hormone. It does this by releasing its own hormone called TSH, thyroid stimulating hormone. So essentially what hormones are, what glands are centers that produce these messengers that then go to other organ systems and tell those organs to do something. And the other examples that we can use are the pituitary gland, as we mentioned, the thyroid gland, but also the female centers of reproduction, the ovaries, the male centers of reproduction, the testes, are also examples of glands.
Right, and there are a lot of glands. I mean, even adrenal glands and thyroid glands, as we're talking about today.
Yes.
So tell me a little bit about the thyroid gland, and we talked about what it does with metabolism, and we want to always be normal, right in the middle.
Yes.
But there are patients and people out here who have their thyroid, they're being told their thyroid is too active or their thyroid is underactive.
Yes.
So we'll start with too active. Someone who is called hyperthyroid, or their thyroid is producing too much. What symptoms, how would they know about it?
So the symptoms of hyperthyroidism, that is a fast thyroid gland, are many. Some people would complain of increased anxiety. Some people would complain of having palpitations or diarrhea or feeling hot all the time or tremulous, shaky in the hands, the inability to write without shaking. These are the very common features that patients would present to us or their primary care provider to complaining of. And then it would be up to the provider to sort of suggest to the patient, well, maybe this has something to do with the thyroid gland, and then of course to order appropriate testing to evaluate that problem.
How about weight loss or weight gain if someone is hyperthyroid?
Yeah, so weight loss tends to go with hyperthyroidism. But some patients will also complain of actually having a ravenous appetite when they have hyperthyroidism. It stimulates those appetite centers, and people tend to be consuming a lot of food.
A lot of times we get blood work. I order blood work on patients. You do, primary care physicians, all of us do.
Sure.
And thyroid testing is very commonly ordered. If your thyroid is elevated, does it mean that you have to have hyperthyroid?
So blood tests are the way we would screen for thyroid disease. Now, there really is not an overall general recommendation of who should be just undergo generalized screening for thyroid disease. We do generally screen for, say, cholesterol problems or sugar problems when we get to a certain age, but really there is no recommendation for screening overall for thyroid problems. So those blood tests, though, can tell us whether the gland has become too fast or too slow, and of course we have treatments that would target whatever problem with those blood tests would indicate.
But the blood tests are not absolute. I mean, that's really what I'm
The
getting at.
blood tests are not absolute. Nothing is. It can be early on in the disease, and the blood tests do not yet manifest the problem. But over time, as a patient develops more severe disease, then the blood test certainly would reveal that particular problem.
Thanks. So now let's talk about hypothyroid, so low thyroid. Tell me a little bit, what would someone complain about if they came to their primary care physician or their friends or their family? What would they say?
So there are a variety of symptoms we see with hypothyroidism, and interestingly enough, some patients experience no symptoms at all with quite abnormal thyroid hormone levels. But some of the symptoms of low thyroid hormone levels include somnolence. Patients would sleep for long periods of time, usually over 10 hours a night, and not be refreshed the next day. Patients complain of fatigue, but that is also possible with hyper as well as hypothyroidism. Weight gain is seen in patients who have been hypothyroid for a long time. At times there's water retention, and so on and so forth. Some patients have changes in bowel habits. They tend to be more constipated during the time that thyroid hormone levels are low, so that is easily corrected with proper thyroid hormone levels. And so as we know, thyroid hormones affect all the organs in the body, so the symptoms, there's a long list of symptoms, but those are the ones we commonly recognize.
So, but you're both saying that almost anything could be related to your thyroid. If you're tired, if you're weak, if you're having weight gain for no reason, weight loss for no reason, all those things could be related to, even palpitations, heart issues could be related to thyroid. So it's important that you think about it and that your internist take a look at it. Is there anything dangerous about this? I mean, when we talk about so many people have thyroid disease, is there anything life-threatening if someone has thyroid disease?
Sure. Just getting back to your other point for a second, many people, these are non-specific symptoms, right? So, you can have a normal thyroid and have these symptoms, and you can have an abnormal thyroid and not have the symptoms, right? So the symptoms don't necessarily diagnose the disease. It's important to get a full evaluation, both by physical exam and with blood work.
So that's the art of being a doctor.
Yes, that's true.
Being able to know what's real and what's not real, and
Right.
not just living by a laboratory value.
That's true. Now, the danger, you mentioned the danger of thyroid disease. Yeah, sure. In severely hyperthyroid patients, the heart can go out of control with respect to the rhythm. We can get a rhythm called atrial fibrillation, which is very important to not only identify but correct, because patients can develop a stroke from that abnormal heartbeat. In some patients, for instance, that have a very, very slow thyroid gland, they can have massive fluid retention. Their heartbeat can actually slow down because they don't have enough thyroid hormone, and they can develop something called myxedema coma. These are extreme examples of severely uncontrolled thyroid disease. But these, that's why it's so important to go to your physician, go to your practitioner, explain whatever symptoms you might be having, so that you don't wind up finding a disease in the advanced stage rather than the early stage.
So now we're having some non-specific symptoms. You go to your regular doctor, your internist, primary care physician. Maybe they get blood work, maybe they don't. Tell me, what criteria do we use to actually diagnose? Is it just on the blood work? You mentioned people who get examined, their thyroid, doctors examine it. How would you go about figuring out if someone has thyroid problems?
So as we know, world of hormones is quite complex. And as you said, blood test doesn't really answer most of the questions. So yes, it's an evaluation that needs to be done by a physician, either primary care or an endocrinologist. It involves blood testing. It involves exam of thyroid, where a physician would actually feel the thyroid gland at the base of the neck, and sometimes even listen to it with a stethoscope. And at times, depending on the disorder of the thyroid, we choose to use imaging tests such as sonogram or ultrasound, or some nuclear tests to clarify the diagnosis, or to help guide the treatment of a certain problem. At times, we use fine needle aspirations, which are biopsies of thyroid. So all those modalities are used, as well as the patient's symptoms, and all that is put together in order to diagnose and treat a particular thyroid illness.
So you have to do a full exam and use imaging studies, almost like anything else.
Right.
So when we have someone with thyroid disease, what can we do? How do we treat it? Is there a way to prevent it from getting worse? Is there anything in someone's diet, lifestyle? Is there anything that we could do to try to, if you were told that your thyroid is out of whack, either stimulant too much, too little, is there anything the person could do to help prevent it, or is it all? And then we'll go on to medications and treatments that we have.
Sure. You know, with regard to diet, it's very interesting. There's a ton of stuff out there on the internet with respect to diet and diet. Some people are telling folks to take iodine. Some people are telling people to avoid iodine. Some people are saying to avoid gluten in their diet, which is the new thing to avoid these days. I guess the question becomes is what is the evidence? What is the science behind that? And really, I tell people that they should have a good diet, good exercise for every reason other than their thyroid. So yeah, you should have a great diet, but I don't think that there's necessarily a body of evidence to suggest that it's going to affect your thyroid in a meaningful way. Now, with respect to how you treat it, well, we treat it, generally speaking, with medications. A slow thyroid tends to be pretty easily controlled. We give patients thyroid hormone. Synthroid is the brand name that many patients are taking. There are others, but this hormone is what we call levothyroxine, and it essentially is the same hormone our body makes. So we supplement that hormone, and it's very easily treated.
Is that a once-a-day pill, or how is it given?
So it's a once-a-day pill. It's once a day, every day, on an empty stomach, generally speaking 30 minutes before you eat or drink anything in the morning.
And it lasts all day?
It lasts all day. It's got what we call a half-life of about 7 days, so it stays in the body for a long period of time.
So if you miss one dose, it's not good, but it's not terrible.
That's correct. And in fact, this is actually a very important point, is that some people, if you forget the pill, you can double up the pill the following day, and you should have no ill effects from that.
Let's talk about some other treatments. So we talked about thyroid, giving thyroid replacement or L-thyroxine, Synthroid. What do we do if the thyroid is overactive?
So if the gland is overactive, we actually have 3 treatment modalities that are available to us. A few years ago, the American Thyroid Association put out a document that it said that all 3 are equivalent and appropriate options for our patients with hyperthyroidism. Everybody, you know, sort of had their approach that they thought was the best, but when the evidence was sort of looked at in this document, they said that really all 3 were appropriate and options. One was giving a drug to slow down the thyroid. Right? We said it's too fast, so this drug slows the gland down. That medicine is called methimazole, and the other drug is called PTU. Both of those drugs slow the gland down. The other approach is to give patients a radioactive pill called radioactive iodine. And what radioactive iodine does is uptaken by the thyroid and actually destroys the thyroid. And when that happens, the patients become hypothyroid and then subsequently need levothyroxine or thyroid hormone replacement. The third approach is actually to surgically remove the thyroid. And again, when you remove the thyroid, we're all talking about how important thyroid hormone is, then those patients also would need thyroid hormone replacement for the rest of their lives.
So there are ways to treat hyperthyroid and hypothyroid.
That's correct.
So now we'll get, to understand it, I mean, we know we've got this gland. Why do people get hyper or hypothyroidism?
So there are, these are recognized as different illnesses, and so the mechanisms behind hypo or hyperthyroidism are, of course, different. Most common cause for failure of thyroid to produce normal amount of thyroid hormones is an autoimmune illness called Hashimoto's thyroiditis, where the body makes these substances that sort of nag at thyroid or maybe destroy some of the active cells. And so at some point, thyroid fails to make normal amounts of thyroid hormones, and the supplementation of thyroid hormone is necessary in the form of levothyroxine or Synthroid.
So basically your body is attacking your own thyroid gland immunologically,
Absolutely.
and that's why it's not working, and that's where we get the hypothyroid. Okay.
Right, so that would be the most common cause of hypothyroidism. Hyperthyroidism, there are a couple of mechanisms behind that as well. Thyroiditis can cause it. That is an inflammation of thyroid, either autoimmune or from other etiologies. There are also toxic nodules. So what that is a simple lump on your thyroid that makes a mistake at some point and makes a bit too much of thyroid hormone for the individual's body's requirement. And so that creates hyperthyroidism situation that is treated in the way described by Dr. Aderbach. At times, there is another autoimmune illness called Graves' disease, named after a physician who discovered it, that has the same mechanism of that we describe for thyroiditis, where our body makes these substances that attack thyroid, but in this case, they stimulate thyroid in the wrong way to make too much of thyroid hormone. And so all that obviously is very interesting and exciting for us endocrinologists, but for patients, they view it as high thyroid hormone levels and they feel unwell, and some of the patients don't really care to discriminate what the mechanism is. They just want to feel better.
Absolutely, that's like everyone else.
Yes.
I think back in medical school, it's always so interesting about Graves' disease is having people who have bulging eyes.
Yeah.
They're called exophthalmos, as you know, where their eyes seem like they're almost coming out of their head.
Yes, it's very frustrating conditions for patients, but it is described in textbooks classically. And we still see these conditions, and sometimes bulging is symmetrical and sometimes it's asymmetrical. It causes quite a bit of frustration for individual patients.
Are there treatments for it?
So the first step would be to control the thyroid hormone levels. And at times, this bulging gets better, and at times it doesn't. And so if it doesn't, patients at times choose to have surgeries that correct this abnormality. So the surgery would involve the eye itself and the reconstruction of the orbit of the eye. However, at times, if it doesn't interfere with vision, and if the defect, if the cosmetic defect is not worrisome, patients remain with a bit of the bulging for the rest of their lives.
Interesting. Tell me about, when I was growing up, you used to hear the word goiter said a lot. Is that a medical term? Is that a colloquial term? When someone would say, I've got a goiter, or someone would have a very thick neck, how do you diagnose it? How do you determine whether it's anything concerning?
Yeah, so I think a lot of people have the image of a goiter in their minds from pictures that they've seen from folks in other countries where their goiters, their thyroid, can come all the way out to here in their neck. And it's something that we don't tend to see in this country for a variety of reasons. One is certainly we wouldn't let it get that big before intervening. And secondly, the whole concept of iodized salt. Our government has sort of made the initiative to enforce that iodine should be in the salt, so that folks don't get goiters as often in this country. And the reason for that is thyroid hormone has iodine attached to it. So when you have an iodine deficiency, people tend to get a very, very large thyroid gland. Now, having said that, goiter, all the word means, and it is a medical term, goiter means a big thyroid. So most of the folks that Dr. Lakina and I see in our office coming to us for thyroid have goiters. They may or may not be visible from the outside, but we can feel it because we know what a normal sized thyroid gland feels like, and we can say, okay, this is a 30-gram goiter or a 35-gram goiter. We can make an assessment as to the size and the weight or mass of the gland based on what we feel. So there are many reasons to have a goiter. Some can be autoimmune, so some patients, as Dr. Lakina pointed out, can have Graves' disease, or they can have Hashimoto's disease, because those antibodies are going after the thyroid gland and causing an inflammatory process. And that's what you're feeling, it's inflamed and large, and that's why the patients have the quote-unquote goiter. Some patients, on the other hand, don't have any of that autoimmunity in their blood. And then the question is, well, why are their thyroids big? And the answer to the question is they just have a big thyroid, just like we have different sized noses, different sized hands. Those patients have different sized thyroid glands. So it can be a sign of something pathological or something wrong, or it can be a sign of just having a larger sized gland than the average.
Thank you for explaining that, because I've heard the term and I've seen it in pictures and in patients. Let's talk a little bit about who should take care of someone who's got thyroid problems. Clearly, our primary care physicians are the people in the forefront. And if you go to your doctor with some non-specific symptoms, whether it's weight gain, weight loss, palpitations, sweating, there's going to be a workup that they do. When does an endocrinologist have to get involved with someone who's got thyroid problems?
I see a lot of patients who have been managed by primary care providers quite well for different thyroid conditions, including hypothyroidism, hyperthyroidism, as well as thyroid nodules. Screening can certainly be done by primary care provider. I think that each individual primary care provider decides what is outside of their scope of practice. And so at that point, the patient is referred. So hypothyroidism, for example, if the patient is on a stable dose of levothyroxine or Synthroid, feeling quite well, that is a condition that can be very well managed by primary care doctor. Hyperthyroidism, again, if the patient is feeling well, managed on medications or with other modalities such as radioactive iodine or surgery, that patient can be managed by primary care provider. If patient is unwell on the recommended treatment or the thyroid hormones remain abnormal despite recommended treatment, I think that patient needs to be referred to an endocrinologist. Not only hormonal abnormalities are important to be treated, but also the thyroid nodules, the structural abnormalities. And so I think that physical exams are very important. Identifying these nodules by just palpating the gland is very important, and that is done at the point of primary care providers when patients come in for their yearly physical exams. And then if the nodule is palpated on exam, primary care providers usually would send such patient for imaging to actually describe the gland in details, and that is done with either sonogram or ultrasound. If the nodules are not concerning for cancer, primary care providers are certainly following these patients. But if the nodules are, if they think the nodules are at risk for thyroid cancer, or if something is not 100% clear, those patients are to be referred to an endocrinologist for further management.
Let's talk about thyroid cancer a little bit. That's clearly people who've had thyroid levels that are high or low. You talked about the treatment, and it seems like we do very well with that. Where have we come with thyroid cancer over the last few years? Is it a disease that people are dying from in high numbers? Are we diagnosing it earlier? And if someone feels a little lump in their neck, is that something that they should be concerned about?
Well, they should be concerned about if they feel a lump in their neck, and certainly they should start by going to their primary care provider, because it could be a lymph node, because they have particularly if it's over here, they could have a dental infection, they could have allergies, they could have a cold. So these questions, the primary care provider will be excellent at evaluating. Certainly imaging is very helpful. However, thyroid cancer, first of all, 2 out of 3 people in the world have thyroid nodules. So don't be surprised if you do a study.
2 out of 3 people in the whole world?
Yes.
Wow.
So if you do an image on their neck, and 95% of those nodules are benign. 5% of the time those cancers can be malignant. So of course in life we want to find the ones that are malignant so we can remove them. So how do we ascertain whether or not they are malignant? Well, we do a biopsy. It's a very simple office procedure. We take an ultrasound probe, we find the nodule, we put the needle in several times to get an adequate sample. We send the sample to a pathologist, they take a look at it and make a determination as to what the nodule is. The vast majority come back benign. As I said, some of them will come back as thyroid cancer, and most commonly the patients will have papillary thyroid cancer, which is a very, very treatable type of cancer. Usually it can be treated surgically without any additional treatment, no chemotherapy, no radiation, nothing like that. Most people, the vast majority of cases, do not die of thyroid cancer, especially the papillary cancer subtype. There is an aggressive type, an extremely rare type of thyroid cancer called anaplastic thyroid cancer. Folks will remember that the Chief Justice Rehnquist of the Supreme Court died of anaplastic thyroid cancer. Again, this is not the type of thyroid cancer that most people get. He had a very, very rare subtype. So most people with thyroid cancer will be treated surgically without any additional treatment and will live normal, healthy lives for the rest of their lives.
And that's marvelous. I mean, that taking some of the fear out of the thyroid cancer is something that's so crucial. And in general way, we're coming to the end. How do you know if you're being treated properly for your thyroid disease? You go to your internist, you go to your endocrinologist, you're given medicine. And I've had so many patients as a neurologist come to me and say, well, they bumped it up a little bit, they went down a little bit. And in a sense, what are you looking for, and what should our audience be looking for to say that they're doing well? Is it just a generalized feeling of feeling good? Does it have to do with being able to exercise, their diet, their weight? Is there anything that hits you as an endocrinologist and an expert in the field of thyroid that would make someone know that they're being treated right, that the right amount of thyroid medicine is being given?
Right. Well, in short, I think that it is important that the patient feels well, right? And then at the same time, patient is to recognize that not only thyroid dysfunction can make one feel unwell, there are many other factors as to why certain symptoms can occur. I think what's the most important factor in this is that patient and the treating physician have this conversation in regards to here are the symptoms and here are the objective evidence such as blood tests and imaging. And so everything has to make sense to a patient. And I think that even if the thyroid hormone levels are adjusted frequently or the blood work is done frequently or something else is maybe done more frequently than the patient desires, as long as there's this open conversation and there's good understanding as to why certain things are done, I think that then that makes patient feel as if they're participating part of the treatment and treated well or correctly, so to speak. And if they don't understand something and they don't get a chance to ask a question, I think such patient is at a loss. Most doctors would do the right thing for the patient, but the patients need to participate in their care, need to understand.
And that's crucial with any field of medicine. As a neurologist, as an endocrinologist, our patients have to be very much involved in their care and seeing how they're feeling. Right. So many times they come to the office saying, you know, I feel good. And if you actually ask them a lot of questions, they're not really feeling that well, if you actually ask the questions. About how often do you see your patients with thyroid disease?
It depends where they're coming for, and it depends where they are in their treatment. Some thyroid patients, particularly if I'm just following a nodule that seems to be inactive, I can see them once a year. If I'm adjusting medicine, particularly in a hyperthyroid patient, I would have them come every 4 to 6 weeks. So it really depends where we are in terms of their treatment, but in the beginning, we tend to see them more frequently. And you know, it also depends on some of their symptoms. Some of them will want to come back more frequently to reassess where they are symptomatically. The discussion you guys were having before, it was great. And I think one of the diagnoses that's important is ruling out other medical causes for symptoms. Big complaint we get is fatigue. Well, there's lots of things that cause fatigue, and one of the most underdiagnosed things in the world is sleep apnea. And I think that many times some of these patients have sleep apnea, and we're trying to make sure that their symptoms are not related to their thyroid, particularly if they have normal thyroid function tests.
I want to thank you guys for being here. It's been a marvelous show. I've enjoyed learning a lot about thyroid disease from 2 experts and how it affects all of the body. And we could talk about thyroid disease for a very long time and all the glands that we have. I want to say thank you again. It was a pleasure.
Thank you.
Thank you
Likewise.
for having us.
Thank you for having us.